Capnography by Dr. Marnaka.
So this is why we're doing all of our changes right here. This is the position statement that was basically put out by the ASA. It was a guideline. It's not a standard of care, so that's obviously an important thing to note. And this was basically put out, or it was effective July 1st, 2011. And I really just kind of highlighted the part that's most important to you guys is during moderate or deep sedation, the adequacy of ventilation shall be evaluated by continual observation of qualitative clinical signs and monitoring for the presence, and that's an important part, the presence of exhaled carbon dioxide. And we'll get into kind of why those certain parts of that statement are important. So my lecture goals today, we'll just, you guys are very intelligent, some of you more than others, so obviously we'll just kind of give a very broad overview of ventilation versus oxygenation. I'm going to kind of go over why pulse oximetry, though being one of the things that have revolutionized ours and your practice, is not really adequate for being the only monitoring of breathing. And then we'll kind of go over why capnography is important. We'll do a little bit of the physiology and biochemistry. Once again, it'll be a very broad overview. Some of the monitoring techniques that we'll be using, and I'll give you some examples. A little bit about waveform analysis, how our nurses are going to be actually interpreting the data, and then we'll just go a little bit over kind of the why the ASA was thinking instilling this with moderate sedation. And then my biggest goal is to hopefully get a little bit of feedback from you guys about, you guys are the primary ones using it. I don't do moderate sedation. I don't know how it is to have interactions with the nurses and what are some of the pitfalls and stuff you guys want to change. So those are kind of an important part for me. So ventilation versus oxygenation. This is all, like I said, stuff that's probably some little bit of review, but the biggest thing, ventilation, is basically the movement of CO2 in and out. That's kind of the biggest thing. And the only way we have to really monitor that is a direct measurement with blood gases, obviously, and then with capnography. And capnography just kind of gives you a general number, assuming all things being equal. It's about 5, the number is about 5 off from what you would get from a blood gas. So very, very similar. And that's with a direct measurement of CO2. Oxygenation obviously just tells us how the body is obtaining and utilizing oxygen. Doesn't really tell you anything about how well the patient's inspiring, expiring, or ventilating. Obviously, it doesn't give you any information on ventilation, and that's pulse oximetry. So typically when you guys are doing your moderate sedation cases, the only thing you really have to look at is pulse ox. Sometimes the nurses will obviously observe the patient, see if there's chest rise, if there's fogging in the mask, but those things can all be kind of misnomers as far as telling if the patient's really adequately moving air. So with pulse ox itself, it's not measuring ventilation, and the limitations really are, for pulse ox monitoring, it's a 3-second delay as it is, just as it stands from when the patient breathes and gets oxygenated to when it's measured at the finger. It's about a 3-second delay. So there's some error there. There's something called apneic oxygenation where patients won't breathe at all, but the diffusion of oxygen in will keep the patient sat very adequately for a prolonged period of time. That whole time the patient may not be moving air at all. And then, as we'll see on the next slide, you can get a very drastic, and you guys have all seen this. This kind of shows a couple things, but the most important thing I want to show here is that whenever you get to that precipice where their PO2 starts to drop off, very small decreases in PO2 will cause drastic decreases in oxygen saturation. So once you get to that point, there's a huge drop off. So it's one of those things where you think you're fine, you get to 91, 92, it's not a big deal, and all of a sudden they just they fall off that precipice, and you're fighting to kind of play catch up. So those are all important things that kind of show your limitations of pulse oximetry. Like I said, this is just kind of what we just talked about. So the nice part about capnography is it actually allows you to monitor ventilation itself. So you can actually see how well the patient's breathing. It adds a layer of protection for patients who are oversedated. It gives you kind of a precursor to if they're starting to get hypopneic or apneic. It'll give you that information immediately. And then it also, we'll see, you can actually, the nurses and yourselves can start titrating the medications based on how quickly the patient's breathing. So ventilation, like we talked about, scrubs CO2. And this is, as just a review, we obviously don't want acidosis. It improves the whole acid-base homeostasis. And then, the other big stuff is the profound sedation. So as patients get more hypocapnic, there's that vicious cycle of they get more sedated. And then they continue to be more hypopneic and get more sedated. So that's one of the big things. Obviously, the acidosis is a huge deal. You can correct that by having them breathe more aggressively or reverse some of their sedatives and narcotics. But obviously, we don't want them to get too acidotic and be arrhythmogenic and have electrolyte abnormalities. And then one of the other things is if you have a patient who has pulmonary hypertension, underlying pulmonary hypertension, hypercapnia, as well as hypoxemia can cause very significant changes in pulmonary vascular tone and can really push a patient over into congestive heart failure or just have other issues in general with their pulmonary vascular tone. So this is just remembering there's two really definitive places that we regulate our breathing. The thing about, this is our primary, obviously, is our central, the fourth ventricle, and that's the most sensitive, especially to narcotics, and it usually responds mostly to pH changes, so our changes in our carbon dioxide is kind of its primary. So obviously, it's something we want to monitor. Kind of going over the effects of what our sedatives are doing. The biggest is obviously our narcotics, very dependent. In very small doses of either Versed or fentanyl, it'll knock out their hypoxemic drive. So really, you're left with your hypercapnic drive. And once you knock that out with increasing doses of medication, they have no drive to breathe other than just the reminder. And you guys, will see this. Obviously, sometimes people just become progressively more apneic, and that's really just kind of knocking out their hypercapnic drive. And obviously, with our COPDers, who are really rely on their hypoxemic drive, once you knock that out with a little bit of medication, their stimulus to breathe is virtually nil. So those are another. Yeah, I'm sorry, Jeff.
No, that's great. Is there a certain dose for that?
No, it's very patient dependent. Obviously, somebody who's on chronic narcotics or chronic benzos, your level is increased significantly. In a normal, healthy, adult females, we always say if they're not overly anxious, well, then you can knock it out very quickly, even with 50 mics of fentanyl and a milligram of Versed. I mean, you don't see that very often in your guys' population because, it's based a lot on anxiety level. And if they're really anxious, which a lot of people are whenever they're having even just moderate sedation, you can get 5-6 milligrams of Versed and 3 cc's, 4 cc's of fentanyl. I'm sure you guys even see more than that sometimes. So I mean, it really depends on what
warning dose that says over 200.
No, absolutely not. And we'll see it. I had a patient the other day who was 40-year-old male. I gave one cc and 1 cc, and he was almost completely apneic. And fortunately, I was in the operating room. But there's no definitive way. And one thing you want to look at too is whether their liver functions are okay, and all those those other things that you guys are kind of keeping an eye on anyway. And obviously, the most sensitive population are elderly population. All right. So really, the practical consideration. How are we going to measure this? That's really kind of what this comes down to is in what way can we really utilize end-tidal or capnography in your practice? And really, there's two ways to measure end-tidal CO2. The first way is directly, and that's what we're doing. You have to have an endotracheal tube to be able to do that, and that's where the absolute number, and I'll talk a little more about that, is important. Whereas indirectly is what the nurses are doing, and really you use a nasal cannula or a mask with the sampling port to get that information. We'll kind of go over the differences. This is typically the nasal cannula you're using, just has the 2 little holes at the bottom. Really gives you just a very basic sampling. This is what we use. We get a little better sample with it. It's just it's just kind of, you put a sampling port into the side and measure that. We actually have masks. Now we're going to try and get masks that actually have a built-in sampling port so that they don't have to do this rigmarole. But if you're not doing an EGD, you're doing a coloscopy or something like that, I always like to use the mask because it's more comfortable for the patient typically too. So what are the differences in measurement? Our direct measurement, we can use the number, the absolute number, the waveform analysis, all to kind of differentiate different medical issues or different, kind of adequacy of ventilation. Whenever you're measuring indirectly, the number is really not meaningful because you're just getting a broad sample from, air as well as what the patient is expiring. So it really doesn't give you a definitive, the number is not definitive as far as, what's going on with the patient. The similarities between the two are the benefits of even indirect measurement is obviously respiratory rate that we'll show you. And it will give you that, because of the respiratory rate, we'll give you that early warning sign of apnea and hypoventilation. And we'll go over a couple waveforms, how we can interpret those. Like I said, numbers are largely useful. The amplitude and frequency may be useful in determining the depth of anesthesia, the comfort of the patient, and that's actually important because you can actually titrate your sedation based on that, and the degree of ventilation in general. and it's very sensitive to apnea. So this is kind of what our normal waveforms look like. You guys have all seen this when you look up and make sure we're awake. It's just a kind of nice, normal, regular pattern. You'll see this more on a direct measurement, but this is how it'll usually look too whenever you're doing an indirect measurement. Obviously, this is when they're not breathing. Even you can figure that out, Pat, right? This is hypercapnia. So a lot of times you'll see this if you have a patient that is really not adequately sedated, is very uncomfortable, but may not be saying anything. You're going to see them start to hyperventilate. And then hypoventilations, like I said, this is all very basic kind of waveform stuff. The issue with this is that this patient, and this is where vigilance pays off with your nursing staff, is this patient will not, there will not be an alarm here. Usually the alarm happens after 20 to 30 seconds. In this circumstance where you get these little blips, the patient's obviously not ventilating, but you're gonna, you're gonna still get, there's not gonna be any alarm. So this is kind of one of the limitations of end-tidal CO2 monitoring, where you still need the vigilance. You can't just rely on your alarms to tip you off. And that's one of the things we've talked to the nursing staff about. So getting, that's just all, pretty basic stuff. Just why, obviously you guys know what moderate sedation is. It's just a depression of consciousness. The ASA felt it was concerning because the spectrum is very, if you have somebody who's under moderate sedation, they're protecting their airway, they're adequately ventilating. But the problem that the ASA had is that the going from a moderate sedation to a deep sedation case is very, it's very blurred, and it's a spectrum, obviously. So whenever you're getting into the deep sedation, they say spontaneous ventilation may be inadequate, and intervention for the airway may be required. So that it's really, we've all had cases where you get to that point where it starts to go into the deep sedation realm. So that's really what they're trying to avoid by monitoring end-tidal CO2, is that you can avoid that, or at least recognize it when it happens. And I think that's really kind of why they went down this road now. And then they always say with the moderate sedation, is what we tell the nurses, is that use it as a tool, use it to titrate meds, to monitor ventilation, but it is not absolute. Just like pulse oximetry, that's a little more definitive, but you still use it as along with the whole clinical picture. So you can't say definitively if the patient's not ventilating until you look at the patient, make sure their nasal cannula didn't fall off or whatever. You have to use it as a full clinical picture. And like I said, with the elderly and the cirrhotics, benzos and narcotics are metabolized much slower. They're much more sensitive to them. And then one of the things we're recommending, and we gave some information to the nursing staff, is to just do a general airway exam, because you really need to hopefully pick up on some of those people that are going to be potential apnea patients, sleep apnea patients, bad airway looking patients. And those are kind of important. So like I said, I really did as thorough of a literature search as I could to try and see if it does change the legal risk for you guys, or the malpractice risk. And really the only thing I found was more for MAC patients or MAC cases with anesthesiologists and their closed claim. One thing I did find is that there was basically just like a letter to the editor within one of the ASA journals that there wasn't information on this yet. Because it's such a new change, we just rolled this out, and a lot of hospitals weren't doing it before. It's going to take a while for the data to come out to see, one, if it improves patient outcome. I mean, I think that's one of the biggest things for us. And then two, does it change the medical legal risk for the endoscopist or whoever's using the moderate system? So I think those are going to be really important things coming down the pipeline in the hopefully in the next year or two, to kind of determine if this is useful. Intuitively, you think it's going to improve patient safety. Obviously, we want your guys' feedback to see if is it distracting the person who's administering the sedation. Is it distracting you guys? Is it helping at all? So we're going to want to know that too. I know it's it's kind of a pain in the butt right now, but it's going to be an ongoing process that I think we all kind of just need to figure out together. It needs to be used as a tool. We've really told the nurses that that's how it's got to be. It's not an absolute number or anything like that. It just needs to be used as another clinical tool to look at. The pulse ox isn't reading, or you're getting a low number, the first thing you do is check the pulse ox, check the patient. So I mean, it's going to be the same kind of process. And I don't think, from what I've talked to the nursing, it shouldn't change at all how the nurses are titrating their sedation. I mean, I know you guys are the primary people saying, titrate to this effect, or give another bit of this, but I think it will be, I think as it gets more useful, or we get some of the kinks ironed out, it'll be actually better for your guys' sedation.